My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Well, thank you, everybody, for participating in our part 1 and part 2 of What Have We Learned About Inflammation and Thrombosis since the COVID-19 outbreak. Part 3, our next discussion, is thromboinflammation, measurement and treatment. Dr. Henry, what laboratory assays effectively measure the progression of COVID-19 coagulopathy?
Well, as you know, George, COVID is a very variable disease. It has a variable presentation ranging from asymptomatic to severe, with a small but significant number of patients developing critical and fatal illness. Now, though we have established risk factors that have proven to be quite true, right, for severe disease or development of severe disease, such as advanced age, obesity, cardiovascular disease, the variability in patient presentation and progression makes clinical monitoring in general a bit tricky, especially at the onset of the pandemic. We were able to identify the hallmarks of COVID-19 associated coagulopathy relatively early on in the pandemic, and these have withstood the test of time. However, we now know, that SARS-CoV-2 impacts all facets of hemostasis, as we talked about in our previous conversations, primary, secondary, as well as fibrinolysis. And this makes monitoring, progression of coagulopathy a bit challenging. But given that, I think sticking to the basics is best. Let's look at a few slides with a little bit more info. Now, what I like to call the early laboratory hallmarks of COVID-19 associated coagulopathy are really 4 things, right? So early on, we see an elevated D-dimer. It's not necessarily going to stay elevated over the disease course, but early on, we do see an elevated D-dimer. And that's really because of activation of fibrinolysis within the lung as we start to develop pulmonary microclots. We have high fibrinogen that's driven by inflammation. We have mildly prolonged PT, as well as sometimes a prolonged APTT. And mild thrombocytopenia or thrombocytosis can also occur, but I generally think I see a bit of a mild thrombocytopenia a bit more frequently. But I would say these are really the 4 key hallmarks of the earliest signals of COVID-19 associated coagulopathy. And all 4 of these, George, we found to be independently associated with poor disease progression and poor outcomes. Now, we also can look at one of the main drivers is sort of this secondary thrombotic microangiopathy phenomenon. And we can look over, in a patient to see whether or not some of these factors, some of these, variables are starting to become evident. We can look at some laboratory signs, such as increasing LDH, decreasing hemoglobin or haptoglobin, elevations in serum creatinine. Of course, that's indicating AKI and end-organ injury, elevation in bilirubin, and D-dimer. Respect to D-dimer, it may be normal, especially after the initial phase, right? Because we talked about, that early on we do have, fibrinolysis, but over time that PaA1 becomes really high, and TPA becomes worn out, and we start to get that, sort of exhaustion of fibrinolysis. So all this might point to a progression, especially to see these changing rapidly, of the coagulopathy and really progressing to that sort of secondary TMA. And even looking at each one of those factors, like I mentioned earlier, we've seen that, independently they're associated with disease progression, severity, and even mortality. Looking at LDH, LDH is a very common, really measured, inflammatory marker, but also measures cell injury, also a major indicator that we use for, evaluating TMA. And we can see that elevations in LDH we found in our own analysis be associated with significantly increased odds, 6-fold increased odds of developing severe disease and 16-fold increased odds if you have elevated LDH of developing fatal and dying from COVID-19. So overall, there are some biomarkers that we can use, but I think overall we want to stick to the basics just because of the complex mechanisms that we see. It's very hard, to say that there are definitive things that we should really be using for monitoring the progression of coagulopathy.
Thank you. Although we're to stick to the basics, we did previously discuss thromboinflammation and its role in driving the pathology. Are there any specific biomarkers for thromboinflammation?
Yeah, good question, George. One biomarker that I've really come to appreciate since the onset of the pandemic is the von Willebrand factor antigen to Adams TS13 activity ratio. Or you can use it backwards. I like Adams TS13 to VWF personally, but both are used. Now, von Willebrand's factor is a large adhesive multimeric protein involved in hemostasis, specifically platelet adhesion via GP1B, as well as binding collagen, factor VIII. It has a number of other functions. The larger the size or number of VWF multimers, the greater functionality of the protein. Now, a deficiency or defect in von Willebrand's factor can lead to something we call von Willebrand's factor disease. That can cause bleeding, while an increase in von Willebrand's factor may cause thrombosis. So low levels, we get bleeding, high levels, we get thrombosis. And thrombosis, especially when we have the high molecular weight form moieties of the protein. However, we have another protein, Adams TS13, and that stands for a disintegrin M metalloproteinase with thrombospodin type 1 motif member 13, very long name, so we'll just call it Adams TS13. And that's primarily responsible for controlling the size of von Willebrand's factor in plasma. So basically goes along and cleaves it. Does it by basically proteolytically cleaves VWF multimers, and thus sometimes called VWF factor cleaving protease. The relationship between von Willebrand's factor and Adams 13 we'll call the von Willebrand's factor Adams TS13 axis. Now, the relative levels of both VWF and Adams TS13 in the normal state can be described as a percentage of normal, which we would basically average to be approximately 100%, right? So they kind of coexist in this balance that maintains normal primary hemostasis. Now, going back to one of our earlier co-ed conversations, we talked about, again, secondary microthrombotic microangiopathy as a driver of COVID-19 associated coagulopathy. And I briefly showed our research on von Willebrand's factor and Adams TS13 in relation to COVID-19 acute kidney injury. What we see in COVID-19 is a major increase in the amount of von Willebrand's factor circulating in blood. And this is due to the pro-inflammatory state, specifically high levels of IL-6, which stimulates the production and release of acute phase reactants, including von Willebrand's factor, as well as other proteins which we commonly associate with inflammation, CRP, fibrinogen, ferritin, but also coagulation components like factor VIII, prothrombin. Right, so we get this pro-inflammation that's really causing this massive release of von Willebrand's factor. And the von Willebrand's factor starts to consume the available Adams TS13 that's around to cleave it. And that results in a decrease in Adams TS13 activity level. Now, it's important to note that this decrease in Adams TS13 is relative. So that, when we measure it in the lab, we see a decrease, but it's relatively mild, nowhere near the levels we would see, for example, in patients with thrombotic thrombocytopenic purpura, or TTP, which is a deficiency of Adams TS13. So it's a relative relationship. In other words, in the presence of this massive surge of von Willebrand's factor, the level of Adams TS13 available is inadequate to maintain normal hemostasis, resulting in a prothrombotic state.
That's interesting. We've talked about MTS13 before and had some discussion last year with Dr. Long Jing from University of Kansas about that. Are there other thrombotic conditions that the VWF ADAM-TS13 axis looks similar to COVID?
Measurement of the VWF Adams TS13 axis is probably a bit underutilized, and in my opinion, probably has significant diagnostic utility outside of COVID-19. I really believe it's key to look at the balance between these two proteins when going through a differential diagnosis, and to give you insight into whether a patient may be more prone to thrombosis risk or bleeding risk. And we have published a few really great papers on this. Let's look at a few slides and we can look how it looks in different conditions. Okay, George, so here we sort of have an overview. I just kind of wanted to point out how the system sort of interplays. And here we can kind of see we have platelets, and on platelets we have the GP1B, and we have our von Willebrand's factor right here. these large multimers of von Willebrand's factor. And what happens is when normal hemostasis, Adams TS13 comes along and cleaves these large multimers of von Willebrand's factor, and that enables normal hemostasis. However, when we have a deficit of Adams TS13 for whatever reason, we don't have that cleaving of von Willebrand's factor, right? And we just get these large multimers that go and bind a bunch of platelets, and these result in thrombosis. So we've published a couple great papers. I put this up here as reference to the listeners to kind of go back to if they're more interested in this topic. So we don't have time to get so in detail, but I'm going to kind of go over the highlights of what we think about when we look at the VWF Adams TS13 axis. So here I put what we expect both in terms of laboratory values as well as sort of a visual representation of the balance between the axes. So in normal individuals, we have a relatively appropriate balance between VWF and Adams TS13, and that maintains proper normal hemostasis. Let's look at a few disease states. Let's start with thrombotic thrombocytopenic purpura. This is a disease where we have some type of deficit in Adams TS13. This could be due to an antibody or some type of genetic condition that results in us not having Adams TS13 available to cleave von Willebrand's factor. What happens is the balance becomes shifted. So we have too much VWF, and that leads to an imbalance. There's not enough Adams 13 available to cleave the VWF, and we get a state in which the ratio is greater than 15 up to infinity, and we get a thrombotic, very high thrombotic risk. When we think about COVID-19, right, we're going to look at a COVID-19. We talked again about the imbalance that we have. We have inflammation-driven release of von Willebrand's factor, so we have a lot of von Willebrand's factor. And though we have normal levels of Adams TS13, it's just inadequate in order to be able to balance out the amount of von Willebrand's factor that's circulating. And like I said, we don't quite see the levels of Adams 13 that we would see in TTP, very low levels. We see a minor drop in activity as it's just used up. The relative balance between the two does result in a significant thrombotic risk. And usually the ratio between that we see, instead of being inappropriate, what we see here between the 0.5 to 2 range, right? It's very close to a 1-to-1 ratio between them. We start to see a ratio that's 2 to 20 in favor of von Willebrand's factor to Adams TS13. That results in this sort of thrombotic risk. We can look a little bit at von Willebrand's disease. We'll look at type 3. Type 3 is when we, as a quantitative, so we do not have von Willebrand's factor at all, when the ratio then becomes very, very low, because we do not have any von Willebrand's factor. We have lots of Adams TS13, and it's just eating up whatever von Willebrand's factor is around, and that leads to significant bleeding risk. We can't maintain proper hemostasis. We can't maintain proper clotting because there's no von Willebrand's factor around. We look at most other forms of von Willebrand's factor. These are more qualitative as opposed to quantitative. Again, a similar situation, not as severe, but again, because Adams TS13 is predominant, at least in relation to appropriate balance, we get a bleeding risk. So overall, looking at the balance between these two, especially when we're not sure about what a patient's condition might be, we're considering about TMAs and stuff, it may prove very useful to consider the balance of these two, and measuring them together may be quite useful.
Oh, this is very interesting to me. Let's move on. Let's talk about therapy. Are there therapeutic avenues explored for targeting the secondary TMA in COVID-19?
Treating secondary thrombotic microangiopathy requires treating the driving force. In this case, it's the thromboinflammation of COVID-19. Evidence to date, sort of paves the way to evaluating specific therapies already in use for other secondary microangiopathies, such as complement inhibitors like eculizumab. Although the results for this in similar agents, including ravulizumab, have not been, I'd say, overly successful in trials. Preliminary data does suggest that the therapeutic approach may complement other therapeutic strategies to improve survival and reduce hypoxia, especially in critical illness. So yeah, they help. I don't know if they're a miracle drug, but they're definitely can play a key role in the illness process, but reducing the illness. But I think, as we pointed out, the picture, the coagulopathy picture, is very complicated. It's very intricate. But at least we can see that targeting complement as a component does seem to reduce the amount of the severity of the illness, and sort of points to, again, that TMA being a driving factor. We can consider the use of recombinant Adams TS13. This is another possible option to sort of counteract the say abnormally upregulated Willebrand's factor in the plasma. However, this still needs to be really tested in future trials. I think another consideration is plasma exchange, which is currently being investigated. There was one small study done by Ruckelman and colleagues. They utilized plasma exchange in 7 critically ill patients, I believe, with COVID-19 and ARDS. And they found, that plasma exchange did, that, and compared to the controls, who, 5 out of 7 controls developed AKI, whereas none of the patients who received plasma exchange developed AKI. So using a therapeutic approach that we use for TTP may also be useful in the management of COVID-19. So I think about those approaches, using complement inhibitors. It's talked about complement as an important component to the TMA driving TMA. Now, Adam's TS13 and plasma exchange are potential therapeutic avenues that are currently being explored for treating, the TMA that we see associated with COVID-19.
Thank you. And one more question I have for you. What do we know about the laboratory values in long COVID, and are there recommendations now for monitoring patients after the SARS-CoV-2 infection?
So as of now, we have relatively limited data on laboratory values in long COVID. A challenge certainly is, and as we talked about previously, that long COVID is extremely heterogeneous with a nearly infinite list of clinical symptoms, variable clinical presentations, and as I mentioned, we talked about, it probably represents several different diseases. Now, a few studies have looked at levels of D-dimer after COVID-19, finding somewhere between 15 and 25% of patients have elevated D-dimer at several months post-infection, which sort of matches the incidence of long COVID. But moreover, it has been demonstrated that this increase of D-dimer is actually independent of sort of the inflammatory picture. Now, looking specifically at long COVID, there was a really great preliminary study by Passini and colleagues looking at 75 patients with long COVID at 2 months post-discharge. And they found that all patients with long COVID had very high levels of, very high serum concentrations of ferritin and D-dimer. 87% had low levels of hemoglobin, 73% had elevations in erythrocyte sedimentation rate, or ESR, and CRP, and 27% had elevations in LDH. Now, to me, this sort of picture of low hemoglobin, elevated LDH sort of hints at a picture of an ongoing thrombotic microangiopathy. But the fact that 100% of patients had elevated D-dimer really suggests that these patients are at increased risk of thrombotic events. And this sort of supports the clinical data that we talked about previously, looking at the elevated risk of MI, the elevated risk of stroke, elevated risk of DVT, PE that we see in patients. So, we have to be very mindful of this. And that kind of leads to the question, what should we be monitoring in patients after COVID? And I think at this point, there's limited data to draw full recommendations upon. However, I think it's reasonable to monitor D-dimer levels in patients with long COVID symptoms, or any patient who may be really at elevated risk, at baseline elevated risk of these types of events, who develop COVID, even if it's a mild COVID. Maybe we should be monitoring those patients a little bit carefully, monitoring their D-dimers, because of what we see from some of these other studies about the long-term cardiovascular outcomes. So I think, we need to evaluate long COVID on a case-by-case basis and consider what testing we should do based on that patient's, particular risk profile. So I think patients who, as I mentioned, already have baseline increased risk of thromboembolic events, we should be monitoring those patients more aggressively, especially if they develop long COVID. And we should possibly consider early anticoagulation during their course of COVID-19, that we kind of consider that we continue at least, throughout this risk period that we've seen is at least 1 year in which there's, increased risk of major thrombotic events. So George, I have to say, we urgently need more studies on laboratory values in long COVID, and our group, will be making this a priority in the coming months.
Thank you. I'm going to just follow up with that D-dimer question again, because the conventional wisdom about D-dimer is that elevated D-dimer is kind of a promiscuous result related mostly just to generalized chronic inflammation. And it sounds like what you're saying is using D-dimer and showing that maybe there's some ongoing thrombotic activity would be an indication for treatment. Am I saying that correctly?
Yes, I think you are. And of course, we don't have definitive evidence, either way, and it's hard to make these generalizations. But yes, I think you're 100% on point. That if I'm saying, if we're seeing patients who have these elevated D dimers after COVID, we should be taking that very seriously. We shouldn't be disregarding that as sort of just a remnant of COVID, that's not harmful. I think we should take it as an ongoing potential risk of something very serious, and address that appropriately. And I think the clinical data we've seen in the past few months, especially these long-term cardiovascular outcomes, really provide the clinical evidence to back up exactly what you just said.
Well, that's very interesting to me, and that really is some new information. Thank you. Well, this concludes today's conversation. Please access all 3 of our co-ed conversations on the subject, what have we learned about inflammation and thrombosis since the COVID-19 outbreak. As you look at the website, you'll see that we'll also have a transcription of these talks, and you're invited to add your comments as well at the end. Dr. Henry, thank you for your expertise, and thank you to the audience for participation in this very fascinating topic. Thank you very much.